A discussion on the biomechanics of adult-acquired flat-foot deformity, stages 1 and 2. When we refer to a flat-foot deformity, we are generally referring to varying degrees of hindfoot valgus, forefoot abduction, forefoot varus, and progressive pes plano valgus, with peritalar subluxation. In an attempt to classify the flat-foot deformity, put simply, it can be understood in 4 main stages. Stage 1 involves only the tibialis posterior tendon. Stage 2 is a flexible deformity. Stage 3 is a rigid deformity. And Stage 4 involves the ankle. We will be focusing on stages 1 and 2. Posterior tibial tendinitis was initially described in 1936 by Kowalski, and in 1989, Johnson and Strom devised a classification system associated with dysfunction of the posterior tibial tendon, also referred to as PTT. Meyerson modified the classification system with the addition of a 4th stage in 1997, and in 2007, Blumen and colleagues refined the classification, which is widely accepted today. Detailed subclassification of stage 2 was described by Haddad and colleagues in 2011, and more recently, Raikin and colleagues classified the deformity based on the rear foot, ankle, and midfoot. Let's go over these briefly in relation to stages 1 and 2. The original classification had 3 stages. Stage 1 describes the condition of the tibialis posterior tendon and clinical findings. Stage 2 describes an elongated tibialis posterior tendon with a mobile but valgus hindfoot, marked weakness with a single-legged heel raise, and positive too many toe sign. Blumen and colleagues felt the wide spectrum of deformity was not completely addressed and refined the classification, which is widely accepted today, and includes subdivisions of the stages based on clinical and radiographic findings. Haddad and colleagues, recognizing overlap in some of the findings in stage 2, expanded the grouping into 5 separate subdivisions. Because most of the controversy in adult-acquired flat foot is associated with the stage 2 deformity, it is recognized to be on a continuum, summarized here. Another commonly accepted classification system to mention is by Raikin and colleagues. This system assesses deformity of the rear foot, ankle, and midfoot independently, with the basis that pathophysiology and natural history may be different at each stage. The key thing to remember in stage 1 is that it can include inflammation of the paratenon, tenosynovitis, or even partial rupture of the PTT, but other deformities are not present or minimal. In stage 2, which has the widest spectrum of subdivisions and debate amongst surgeons, is a flexible deformity, with many classification systems and subdivisions due to the difficulty in having one umbrella term for patients who fit within this stage. On the medial side, we will discuss the tibialis posterior tendon, the spring ligament complex, and the deltoid ligament complex. Then we will move over to the bony changes that occur with the progression of medial column instability, with peritalar subluxation and/or naviculocuneiform subluxation. The tibialis posterior tendon was originally described as the main cause of flat foot due to the degeneration, weakening, and tendinosis that developed, which in turn resulted in compromised strength and affected function. Now maybe it is the abrupt change of direction with increased gliding resistance, or the hypervascular zone, located about 1 to 1.5 centimeters distal to the medial malleolus, that contributes to insufficiency. But either way, its main action as an inverter and stabilizer of the longitudinal arch of the foot, along with the spring ligament, plantar fascia, and plantar ligaments, may play a role in the progression of a flat foot deformity. The strength of the tibialis posterior can be tested with the patient in a seated position, the foot plantar flexed and everted by asking the patient to invert the foot. The spring ligament complex on the medial side of the foot may develop tears or attenuation, which affect the ability to prevent lateral translation of the midfoot. More recently, involvement of the spring ligament has been questioned as to whether it may actually be the driving force behind the adult-acquired flat foot deformity. It is widely accepted that its involvement is nearly as common as pathology in the tibialis posterior tendon itself. The deltoid ligament is in close association with the spring ligament complex. As these tissues attenuate, this may lead to valgus deformity of the ankle, and over time, progression to stages 3 and 4, where arthritic changes may be seen in the ankle joint. Appreciating the support the deltoid and spring ligament complex provide to the medial side, in addition to the capsular tissue, we can understand that when these medial soft tissues become insufficient, the joint is not supported, and at the talocalcaneal and talonavicular joints, peritalar subluxation can occur. Appreciated here in the video, we can see the talus and calcaneus, and the subluxation in both the sagittal and axial planes. How the talar head would no longer be fully covered by the navicular, and the cascade of the longitudinal arch collapsing, with subluxation of the talonavicular, naviculo-cuneiform, first tarsometatarsal joint, or a combination. One way to identify the degree of subluxation is on an AP X-ray, where we look at the talonavicular joint and see how much of the talus is covered by the navicular. Looking at the amount of the talar head that is uncovered by the navicular helps with the staging of the deformity. In this case, there is uncoverage of over 50% of the talar head, suggesting a more severe deformity. On the lateral X-ray, we can also see the talus angled downward, and a line can be drawn from the longitudinal axis of the talus and the first metatarsal, known as Meares angle, which can identify the talar first metatarsal angle. Subluxation can also happen more distally, at the naviculo-cuneiform and even the first tarsometatarsal joints. Moving to the hindfoot, we have the equinus contracture and the hindfoot valgus. There is some debate about which comes first. If we look first at the muscle and tendon compartment and think of a normal Achilles tendon, this would normally produce a supinator effect over the hindfoot. Instead, when inserted in a valgus heel bone, it becomes a pronator, which exacerbates the deformity. Shifting the heel medially can help correct this. When assessing the patient, we are looking at flexibility and whether the heel goes from a valgus to varus position with weakness of the tibialis posterior tendon. This leads to an inability to invert the heel, as there is no rigid lever arm for the gastrocnemius muscle to contract against. Hindfoot valgus, assessed on the patient from behind, results from the pronation and eversion motion at the subtalar joint. The interosseous ligament between the talus and calcaneus is normally involved as it works hard to prevent excessive movement of the subtalar joint. In these videos, notice that not one movement happens in isolation, and there is a combination of subtalar joint movement with peritalar subluxation and hindfoot valgus. Looking at the changes that happen on the lateral side, which generally is relative shortening perceived in the early stages of adult-acquired flat foot, when the forefoot abducts. You notice the cuboid, which follows the calcaneus, and then the forefoot, which follows the cuboid, move towards the lateral column and abduct the forefoot. So finally, let's look at these changes in the forefoot, where abduction is observed anteriorly, and then posteriorly by the too many toe sign. In most cases, this is a consequence of the rest of the changes happening in the foot, so the forefoot acts as a compensatory mechanism. The same is seen with forefoot varus, where the position of the forefoot relative to the hindfoot is assessed by looking head-on and determining the degree of elevation of the first ray relative to the fifth, and whether this has been a compensatory mechanism due to a hindfoot deformity. With all the changes that can happen, the development of a flat foot can be viewed on a spectrum. There is no agreed consensus on the progression. However, it is agreed that as certain changes worsen, the flat foot progresses from a flexible to a fixed deformity. It is important to recognize some of the causes of flat foot to distinguish if it is a progressive collapsing flat foot deformity, recognized as the so-called adult acquired flat foot, or a flat foot as a result of a developmental cause or an acquired condition. Factors like aging, hypertension, diabetes, and obesity are associated with flat foot deformity and affect women more frequently than men, peaking at 55 years of age with just over a 3% prevalence in women over the age of 40, as seen in the UK. When the patient presents in the early stage, the main symptom is pain along the posterior tibial tendon. As this progresses, the patient often reports a change in the shape of the foot, increased pain, and difficulty with weight-bearing activities. In addition to the routine foot and ankle exam, the examiner should focus on key findings related to flat foot deformity. Confirm tendon continuity. This patient should be able to perform a single leg heel raise. The hindfoot should show 5 degrees or less of hindfoot valgus, which distinguishes stage 1 from stage 2. The Harris mat technique can be used by taking an imprint from the patient, which is then bisected by a line drawn from the middle of the second toe to the middle of the heel imprint. At the midpoint, a perpendicular line is drawn with measurements. A grade of 2 or greater is considered a moderate or severe flat foot deformity. Radiographs should include weight-bearing AP and lateral, with attention paid to any signs of degenerative change, instability, plantar gapping in the tarsometatarsal, naviculo-cuneiform, and talonavicular joints. There is a lack of commonly accepted reference points and angular measurements, and some view radiographic parameters as secondary to the clinical appearance of the foot. A couple to mention include the talonavicular angle mentioned earlier, calcaneal pitch, which is formed by the intersection of the line drawn along the plantar surface of the calcaneus and a line drawn parallel to the ground, and also hindfoot alignment views. Ultrasound has its place in assessing the tendon and surrounding structures in the early stages of the deformity. MRI can confirm posterior tibial tendon dysfunction and assess both the spring ligament and deltoid ligament complex. Selective injections into isolated joints can be helpful. Non-operative treatment in the early stages of the deformity can include custom orthoses, particularly semi-rigid foot orthoses for arch support. Finally, physical therapy, anti-inflammatory medications, and selective injections may be beneficial in the early stages.
For a discussion on the biomechanics of stages 3 and 4 adult acquired flat foot deformity. When we refer to a flat foot deformity, we are generally referring to varying degrees of hindfoot valgus, forefoot abduction, forefoot varus, and progressive pes planovalgus with peritalar subluxation. In stages 3 and 4, the abnormality has progressed to a fixed deformity, where some joints are now degenerative and the ankle joint and deltoid ligament complex are involved. In an attempt to classify the flat foot deformity, put simply, it can be understood in 4 main stages. Stage 3 is a rigid deformity, and stage 4 involves the ankle, bearing in mind that there is controversy in classification systems, treatment algorithms, and adjunct procedures needed to treat the flat foot deformity. This video covers just the surface in this complex topic. Posterior tibial tendinitis was initially described in 1936 by Kolowski, and Johnson and Strom devised the classification system associated with dysfunction of the posterior tibial tendon in 1989. Meyerson modified the classification system with the addition of a 4th stage in 1997. Blumen and colleagues in 2007 refined the classification, which is widely accepted today. More recently, Rakin and colleagues classified the deformity based on the rear foot, ankle, and midfoot. Let's go over these briefly in relation to stages 3 and 4. The original classification has 3 stages. Stage 3 describes the elongated tibialis posterior tendon and clinical findings with a fixed hindfoot and marked degeneration in the joints. Meyerson's 4th stage describes the involvement of the tibio-talar joint with valgus tilting. Blumen and colleagues felt the wide spectrum of deformity was not completely addressed and refined the classification, and includes subdivisions of the stages, with the focus in stage 3 on the rigid hindfoot valgus and forefoot abduction, and in stage 4 where the ankle joint is rigid or flexible. Another commonly accepted classification system to mention is by Rakin and colleagues. This system assesses deformity of the rear foot, ankle, and midfoot independently, with the basis that pathophysiology and natural history may be different at each stage. Stage 3A and 3B focus on the arthritic changes in the rear foot, ankle, and midfoot. Now that we've discussed some of the classification systems, let's look at other factors related to adult acquired flat foot. For the purpose of this video, we will address this three-dimensional deformity from the medial side, then the hindfoot, followed by the lateral side, and finally the forefoot. We will then break this down into how soft tissues contribute to the flat foot and the bony deformities that develop as an end result of the abnormal loading of the joints, which may have been caused by arthritis. On the medial side, we will discuss the deltoid ligament complex and then move over to the bony changes that are now being affected by arthritic changes in the joints, specifically in the talonavicular joint and/or naviculo-cuneiform joint. With the deltoid ligament compromised in a large portion of patients due to the chronic strain put on the ligament, we start to see deformity at both the ankle and subtalar joint. The talus, having been subluxed over a period of time, may have developed degenerative changes in the talonavicular joint, and with this comes pain and stiffness, sometimes with a rigid deformity that is unable to be reduced. One way to identify the degree of subluxation is on an AP X-ray, where we look at the talonavicular joint and see how much of the talus is covered by the navicular. Looking at the amount of the talar head that is uncovered by the navicular helps with the staging of the deformity. In this case, there is uncoverage of over 50% of the talar head, suggesting advanced deformity. On the lateral X-ray, we can also see the talus angled plantarly, and a line can be drawn from the longitudinal axis of the talus and the first metatarsal, known as Meary's angle, which can identify the talar first metatarsal angle. This patient has subtalar arthritis and naviculo-cuneiform degeneration, which has led to collapse of the medial column. It is important to look for the joint with the greatest amount of deformity, also referred to as the apex of the deformity, and begin surgical correction by reducing this most severe deformity appropriately. Moving to the hindfoot, looking first at a tight gastroc soleus and/or Achilles tendon, we note that a normal Achilles tendon produces a supinator effect over the hindfoot, but when the tendon inserts into a valgus heel bone, it becomes a pronator, exacerbating the valgus deformity. A tendo-Achilles lengthening is often required as part of the flat foot correction. Patients with a rigid deformity find it almost impossible to perform a single heel raise. Hindfoot valgus, assessed on the patient from behind, results from the pronation and eversion motion at the subtalar joint that is unable to be reduced. As the head of the talus drops plantarly, the calcaneus drifts laterally and posteriorly. In some patients with long-standing deformity, the calcaneus can be seen with a huge valgus deformity that has progressed and now causes subfibular impingement. In late presentations, some patients will actually report the pain on the lateral side of the ankle. Seen here on an AP X-ray of the ankle, there is impingement from the calcaneus on the tip of the fibula or lateral process of the talus, and this may cause cyst formation or sclerosis. In the progression to stages 3 and 4 of the disease, the subtalar joint shows signs of arthritis due to degeneration in the joint. Observe the movement at the joint and how the medial arch completely collapses when the posterior facet of the talus bottoms out and impinges in the sinus tarsi. Tibiotalar, or ankle valgus, tends to happen towards the end of the spectrum of the flat foot progression, as chronic changes in the medial soft tissues leave them unable to support the medial longitudinal arch, which collapses. Increasing pressure on the ankle joint can lead to degenerative changes. The ankle must be assessed to determine whether it can be reduced into the mortise or not. If it is a fixed deformity, fusion procedures need to be performed for correction. Moving on to changes on the lateral side, where we have the unopposed peroneus brevis, which is the principal antagonist to the tibialis posterior tendon, now adding to the deformity and the relative shortening of the lateral column, where the cuboid, which follows the calcaneus, and then the forefoot, which follows the cuboid, move towards the lateral column and abducts the forefoot. The forefoot will have abduction, seen here anteriorly and seen here posteriorly by the too many toes sign. In most cases, this is a consequence of the rest of the changes in the foot. We mentioned forefoot varus and supinatus in the same section because even though forefoot supinatus is the reducible deformity, the term is used interchangeably with forefoot varus, and it is difficult to distinguish between the two. To clarify, forefoot varus is an osseous deformity that induces subtalar joint pronation, whereas forefoot supinatus is acquired and develops because of subtalar joint pronation. Fixed forefoot varus is more difficult to detect when hindfoot deformity is rigid, because hindfoot reduction may not be possible until the correction is done at the time of surgery. After a triple fusion, where the forefoot varus was not addressed, there will be lateral foot overload, eversion at the ankle joint, and medial column stress and failure of the deltoid. It is important to recognize some of the causes of the flat foot so we can distinguish if this is a progressive collapsing flat foot deformity, recognized as the so-called adult acquired flat foot, or a flat foot as a result of a developmental cause or an acquired condition. Factors like aging, hypertension, diabetes, and obesity are associated with flat foot deformity. Women are affected more frequently than men, with a peak age of 55 years and a prevalence of just over 3% in women over the age of 40, seen in the UK. When the patient presents in the later stages of the disease, they often report a change in the shape of the foot, increased pain, and difficulty with weight-bearing activities. In addition to the routine foot and ankle exam, the examiner should focus on key findings related to the flat foot deformity. Observe standing alignment, particularly looking at the extent of hindfoot valgus, midfoot pronation, and forefoot abduction, and assess whether the deformity is flexible or fixed. Radiographs should include weight-bearing AP and lateral views, with attention paid to signs of degenerative changes in the joints and any ankle deformity, and hindfoot alignment assessed. Selective injections into isolated joints can be helpful. Non-operative treatment in the late stages requires modified footwear and pain management. Failure of non-operative management may lead to operative treatment, where the surgeon will assess which procedures are needed to correct the deformity. Finally, the goals of surgical management are to restore a plantigrade foot that is stable and functional with minimal pain. Discussion on the general surgical considerations of adult acquired flat foot deformity in stages 1 and 2. Before we get started, it is important to note that there is controversy in treatment algorithms and adjunct procedures needed to treat the flat foot deformity, and this video helps to cover general considerations of this complex topic. The goals of surgical management are to restore stability and functionality to a plantigrade foot with minimal pain. On the medial side, we will highlight some procedures that are performed to correct the pathology associated with tibialis posterior tendon insufficiency, the attenuated spring ligament, the deltoid ligament complex, and the bony corrections that address medial column instability. Joint fusion procedures will not be covered in this topic. However, based on patient factors, in rare cases, this may be the preferred surgical solution. Procedures associated with the tibialis posterior tendon include either an open or arthroscopic tenosynovectomy and assessment of the degenerative posterior tibial tendon to decide whether it will be preserved or excised, augmented, replaced, or tenodiced. Most surgeons choose to excise a non-functioning tendon that is a pain generator. The transfer of the FDL tendon to the navicular can help restore the action previously controlled by the tibialis posterior tendon. It is transected just proximal to the master knot of Henry and is normally the tendon that is transferred to either the navicular or medial cuneiform and can be secured with suture anchors, interference screws, a suture button construct, or sewn back onto itself. The benefits include being in close proximity to the PTT and having in-phase firing during the gait cycle and limited functional loss for the patient. The soft tissue repair of the spring ligament can be performed either through direct repair, imbrication, or graft reconstruction with or without internal brace ligament augmentation, which provides improvement in talonavicular uncoverage and medial sag. If using the internal brace ligament augmentation, it can be placed in the same orientation as the FDL tunnel, passed into the navicular, and secured with a tenodesis screw. The deltoid ligament complex should be repaired or reconstructed as needed, bearing in mind that medial ligament reconstruction attempts will fail if residual coronal plane deformity persists. Options can include an all-suture repair if there is good tissue, a repair with suture anchors with or without the use of internal brace ligament augmentation, which uses a fiber tape ligament augmentation over the repaired native tissue. If there is inadequate tissue for a repair, a reconstruction technique can be used. Once adults develop a rigid arthritic flat foot, joint sparing procedures are no longer sufficient, and in order to correct the deformity, fusion procedures are considered. One specific fusion we will discuss is the first tarso-metatarsal fusion, or Lapidus procedure, which was described in 1934 for hallux valgus correction. Its use has been expanded to correct the medial column deformity in adult acquired flat foot, seen here in combination with an FDL transfer and a spring ligament internal brace ligament augmentation, an Evans osteotomy, and a calcaneal slide. Moving on to the hindfoot, where we address the equinus by performing a release of the gastrocnemius, soleus, Achilles tendon, or a combination to ensure the ankle can dorsiflex. This can be addressed at different levels. A couple popular ones include a release at the distal gastrocnemius level, known as the Strayer procedure, which can be performed open, endoscopically, or more distally, a tendo-Achilles lengthening, described by Hoke. To correct hindfoot deformity, multiple options of osteotomies exist. The most common osteotomy is the medializing calcaneal osteotomy, which will convert the gastroc soleus from an everter to an inverter of the heel, as it helps to restore the gastroc soleus axis with the ankle joint. An osteotomy is made in the body of the calcaneus, at a 45-degree angle with the sole of the foot. The amount of shift is patient-specific, but translation of 10 millimeters has been shown to decrease the load on the first metatarsal, medial arch, and the moment at the talonavicular joint, and increase the load on the lateral foot. An inferior translation of the distal fragment can be added in order to restore the normal calcaneal pitch angle. This procedure can be performed either open or with minimally invasive instrumentation to bring the heel more medial and allow the Achilles to function more effectively. An arthroeresis implant inserted into the sinus tarsi may be used to assist in treating the hyperpronated foot by stabilizing the subtalar joint, blocking the forward, downward, and medial displacement of the talus. An arthroeresis implant may also help in reducing the talonavicular joint, thereby limiting excess valgus of the hindfoot. It was originally designed for pediatric treatment to correct the flat foot deformity while preserving foot function. In the adult, it tends not to be a standalone procedure. On the lateral side, procedures include lengthening the lateral column, which can be performed by distraction, placing graft in the calcaneal osteotomy or in the calcaneo-cuboid joint, resulting in the elongation. With distraction, an opening 10 millimeters from the calcaneo-cuboid joint can correct abduction, restore talonavicular coverage, and correct eversion while preserving motion. In 1961, Evans described the procedure, in which he lengthened the lateral column in the congenital spastic flat foot, so the procedure is also referred to as the Evans procedure. Here, the column is lengthened with a biosync reconstruction wedge, but a plate or an allograft could also be used. It is worth noting that the commonly referred to short lateral column may be relative shortening, and any attempt at lengthening may increase pressure at the calcaneo-cuboid joint, causing improper rotation of the forefoot in varus and supination. There can also be impingement found in the sinus tarsi. A double calcaneal osteotomy incorporates a medializing calcaneal osteotomy to correct the hindfoot valgus, with a lateral column lengthening to correct forefoot abduction and increase arch height, which can be seen here using an allograft wedge and stabilized with an X-plate. Finally, the forefoot, which technically can be grouped in the medial bony corrections, but as it relates more to the correction of the forefoot, we have grouped it here. In 1936, Cotton described an opening wedge, medial cuneiform osteotomy, to plantar flex the first ray. It is performed at the center of the medial cuneiform, perpendicular to the long axis of the bone, and a 5 mm to 8 mm wedge of bone graft, either an autograft, an allograft, or a reconstruction wedge, is inserted. The goal is to flex the medial column and correct supination, and is normally an adjunct procedure. Postoperatively, guidance can vary depending on the procedures performed. The patient is normally protected for 6 weeks after any medial soft tissue repair of the spring ligament, deltoid ligament, or tibialis posterior tendon, with or without FDL tendon transfer. Once adequate soft tissue healing has occurred, a PT program may be started, with an insole sometimes needed long-term. For a discussion
on the general surgical considerations of adult-acquired flat foot deformity, stages 3 and 4. Before we start, it is important to note that there is controversy in treatment algorithms and adjunct procedures needed to treat flat foot deformity. This video covers general considerations of this complex topic, specifically related to stages 3 and 4 of adult-acquired flat foot deformity, or the recently termed progressive collapsing foot deformity. The goals of surgical management are to restore a plantar grade foot, making it stable and functional with minimal pain. For the purpose of this discussion, we will address procedures as isolated pathologies. This is not normally the case, as the disease process is multifactorial and many procedures can be combined as needed to correct the deformity. On the medial side, we will highlight some procedures associated with the attenuated deltoid ligament complex and the bony corrections that address medial column joint degeneration. For the hindfoot, we will address equinus contracture and hindfoot deformity due to degeneration of the joints. On the lateral side, we will address the lateral column, and with the forefoot, we will review compensatory surgical options available to treat varus deformity. The deltoid ligament complex should be repaired or reconstructed as needed. Options include an all-suture repair if there is good tissue, a repair with suture anchors with or without the use of the internal brace ligament repair, which secures the repaired native tissue with fiber tape suture, or a reconstruction if there is inadequate tissue for a repair. Bear in mind that medial ligament reconstruction attempts will fail if residual coronal plane deformity persists. Once a rigid arthritic flat foot develops, joint-sparing procedures are no longer sufficient, and to correct the deformity, fusion procedures should be considered. These joint fusions can be fixed with the surgeon's choice of hardware, whether it be screws, plates, staples, or a combination. Typically, the talonavicular joint is reduced first, as it is normally where the apex of the deformity is. This can be fixed with either screws, staples, or a plate. It also allows for correction of midfoot abduction. Distally, the joint can be fixed or even combined with a first tarsometatarsal fusion. The choice is patient-specific, and correction of midfoot instability can be a combination of talonavicular, navicular cuneiform, and first tarsometatarsal joint fusions. More severe or arthritic deformities on the medial column can be combined with a triple fusion in the later stages of the deformity as needed. We will address the triple fusion in more detail later. Moving to the hindfoot, we address the equinus through releasing the gastrocnemius, soleus, or Achilles tendon, or a combination, which would ensure the ankle can dorsiflex. This can be addressed at different levels. A couple of popular ones to mention include a release at the distal gastrocnemius level, known as the Strayer procedure, which can be performed open or endoscopically, or more distally, a tendo-Achilles lengthening, described by Hoke. The subtalar joint is arthritic in the later stages of the deformity and has a fixed hindfoot valgus deformity, requiring a subtalar fusion. Correction of the valgus deformity can be corrected through joint preparation. The use of a laminar spreader between the lateral process of the talus and anterior process of the calcaneus can aid this. If there is deformity and degeneration in both the subtalar and talonavicular joints, correction is referred to as a double fusion. A double fusion is seen here with 2 screws in the subtalar joint and 2 more in the talonavicular joint. Stage 4 flat foot deformity is characterized by deltoid ligament failure and involvement of the ankle joint. Some patients have tibio-talar involvement with a flexible flat foot where previously described procedures can be performed, and the ankle treated by reconstruction of the deltoid. Patients with long-standing rigid flat foot deformity may develop ankle arthritis with valgus tilt and deltoid ligament incompetence. Based on clinical presentation, in a rigid deformity with ankle involvement, a double or triple arthrodesis with either an ankle replacement, ankle fusion, or pantalar fusion can be performed. A tibio-talar calcaneal fusion may be required for those with severe ankle valgus and peritalar subluxation to achieve a plantar grade, stable, and functional foot with minimal pain. On the lateral side, a calcaneocuboid fusion may be performed, which is normally undertaken as part of a triple arthrodesis procedure. Originally described by Ryerson in 1923, the triple arthrodesis is a powerful and reliable procedure for stabilizing and correcting painful, rigid, flat foot deformities. The talonavicular joint is reduced first, followed by the subtalar joint, restoring a plantar-grade foot with approximately 5 degrees of hindfoot valgus alignment. Finally, let's discuss the forefoot for stages 3 and 4, where correction of residual forefoot varus may be required. In 1936, Cotton described an opening wedge medial cuneiform osteotomy to plantar flex the first ray. It's performed at the center of the medial cuneiform, perpendicular to the long axis of the bone, and a 5 to 8 mm wedge of bone graft, either autograft or allograft, or a reconstruction wedge, is inserted. The goal is to flex the medial column and correct supination. This is normally an adjunct procedure. This example of a stage 3 deformity shows correction with a double fusion and a Cotton osteotomy. Finally, with fusion procedures, there is a period of non-weight bearing before progressing to partial and full weight bearing. Progression is patient-specific and can sometimes require a prolonged period of protection in a plaster cast.